paediatric rheumatology, so I've done my grid training between Glasgow and Great Ormond Street, and I'm currently working a bit between Lothian and Glasgow, so I'm doing some Edinburgh clinics as well.
So that's great, and you've got experience of both big centres, so that's good to have for tonight's
really
talk.
good.
So thank you for coming to talk to us about transition, and if anybody's got any questions, you can either, maybe at the end, it's probably easier because it's Zoomed rather than any other way of asking them, but you could either put them on the chat bar or you could ask at the end. Is that okay with you, Kat?
Yeah, absolutely fine. Sometimes if you're presenting, I can't really see the chat, so if there is, I'm happy for anyone to interject at any point, just let me know, so because sometimes I won't be able to see.
I'll monitor the chat bar for you, Kat. So
thanks, Lewis. Yeah. And I'll just put my video off if that's okay.
Yeah, and I think what we'll do, Kat, is that we'll all mute ourselves so that there's no background noises or anything else. Okay.
Sounds good.
So unfortunately that person's left, but I'm sure she might come back just to try that again. So I'll keep an eye for her joining. Okay. Yeah. Thank you.
Okay, so thanks for that. So as I said, my name is Kat. I'm one of the rheumatology doctors currently working in Glasgow, and I thought we could have a chat about transition. It's something I'm quite interested in. Adolescents are a group of society that really fascinate me. And I think they get a bit of a hard rep, actually. I think a lot of the time we can be quite sort of, oh, they sleep late and they're up late and they do this and they do that. And actually, I think it's been shown there are some very important biochemical and neurological changes that happen in adolescence, and there are clear reasons for the changes in their behaviour. And I just think as a group, they are perhaps poorly understood at times. And in medicine, it's quite hard to be an adolescent because there's the paediatric services, which are quite smiley and we've got clown doctors and Teddy Hospital, and then you come and bright colours everywhere. And then you've got the adult services, which, having attended the adult services myself, can be quite stark and quite bish bash bosh, and in you come, out you go. And in paediatrics, we can be very mollycoddling actually of our patients, very protective and very, very supportive. And in adults, there isn't really going to be anyone chasing you, particularly if you don't pick up your methotrexate or you don't come to the day ward for your infusion. So I think there needs to be this process from being a child in paediatric services with a chronic condition to being empowered and taking ownership of your own health as an adult. And that whole adolescent period in between, I think it just can be hard. So let me see if my slides are now going to move. That would be good if they moved. Oh, sorry, they don't seem to be moving. That's not very good. Oh, there we go. So I'd just like to give some acknowledgements to Dr. Jo Walsh and Dr. Elaine Morrison, who work in Glasgow, for some of the content of this talk. So what we always talk about wanting to give young people a good transition to adult services. And hopefully this talk will cover what transition is, what recommendations are in place, and what we would like, what we consider a good transition and working towards it. So the World Health Organization has a few different definitions relating to young people. So an adolescent is someone between the age of 10 and 19. A young person is someone from 10 to 24, and a young adult is somewhere between 16 and 24. So, so adolescence actually is a huge chunk of your early years and starts earlier in terms of this definition than I think I ever realised. And as I alluded to earlier, it is a period of profound personal change and development for young people. So the Society of Adolescent Health and Medicine gave some goals for an organised, coordinated transfer to adult care for young people who have chronic conditions, and they were to optimise the health and facilitate each young person attaining their maximum potential. And that's really what we're wanting to achieve. So what is transition? There's a definition that I quite like. It's old, 1993, but transition is a planned process, a purposeful planned process for adolescents with chronic physical and medical conditions as they move from child-centred to adult-orientated healthcare. And what I like about that is that it is a process. It's not just that, oh, you turn 16 or 18, we've referred you to adults, off you go. This is by saying it's a process, it suggests it's over a long period of time. And really during that time, we want to address their medical needs, obviously, but also their psychosocial needs and their educational and vocational needs. Most of our patients, it will be educational needs because most are school age, but we do have a cohort of young people who've perhaps left school for certain reasons and need some good old practical advice about the workplace and their condition and support for work. And these are all really important things because life isn't just your JIA. There's so much more to life than that. It should be this tiny part as part of you. It doesn't define you. So we really need to look at each person individually and think about the holistic picture. And also transition really is a process whereby I feel strongly about the young person being empowered. So the young person's asking questions about their condition. Well, why do I need that medicine? What does it do? You know, does it mean I can't drink alcohol? Does it mean, like, having a voice to ask questions that worry them, which I think can be hard. And I actually think building up that relationship with a young person over time so they feel empowered to ask questions is important, because although I think in my head that I'm down with the teenagers, I'm really not. To them, I'm an old woman. You know, I really, you know, like someone once said they really liked Kylie, and I said, oh, Minogue, and they said, no, Jenner, and I thought, oh God, I'm really like out of this. So you know, so to me, to them, we're old men and women asking them personal questions, and they're not really going to want to chat. So I think developing those relationships and empowering young people in whatever way we can for them to feel comfortable to chat to us and open up is important. So why is it needed? So I haven't found a specific rheumatology-based research regarding this, although I can have another hunt, but there has definitely been a reported increase in morbidity and mortality in children and young people who have renal disease, heart disease, diabetes, who go to adult services if they have not had a inverted commas good transition process, or in fact, a transition process of any kind. In Canada, they looked at patients who'd had renal transplants and looked at those who went to adult services with transition versus without. And those who hadn't had any form of transition, 25% of them lost their transplanted kidney. And that is devastating. That's a devastating consequence after what they've been through to lose that transplanted kidney, versus 0% in the group who had transition, thereby suggesting that that process of transition enabled the people to know about their condition, understand their condition, attend appointments, comply with medication, perhaps because there's more of an understanding about the importance of it. So it's been proven to be medically beneficial to have a transition process. So it increases the young person's ability to manage their own health responsibilities and hopefully will influence the future engagement with healthcare services. I mean, I always get, you know, I find it very upsetting when we refer a young person to adult services and you find that they've kind of dropped off the radar or they're lost to follow, you know, that kind of thing. There's only so much chasing that the adult services will do, if that makes sense. You know, once you're an adult and you need to sort of own your condition and attend your own appointments, there won't be mum or dad or the rheumatology nurse chasing you necessarily when you pass a certain point. So we hope to encourage engagement with healthcare services in the long term, and it improves short and long-term clinical outcomes also. There's been lots of guidance through various forums. So the purple one is the BSPAR Standards of Care for Children with GIE, which you may be familiar with. There's also been guidance from the Royal College of Physicians. There's been and there's been a quality care Commission, or sorry, Care Quality Commission, I never get it right, the English body, CQC, has developed a report about transition with guidance as well. So there's a lot of guidance out there about how it should be done, but how does that translate into practice? So the BSPAR standards of care state that age and developmentally appropriate individualised transitional care for children and young people with GIA should occur addressing the medical, psychosocial, educational, vocational issues. And it should take place reflecting early, mid and late phases of adolescent development, which I think is interesting because, as we saw from the sort of definition of adolescence, that goes on from 10 to 19. So it's a long old time during which the young person is having a lot of important changes. So really, we want a process that goes through that time. I won't read this all out to you, but this is just to highlight the recommendations in the BSPAR standards of care, and also just to show, I think there was a young person who was 13 and mum said, oh, I don't know if we're a bit premature coming here, but you can see it says individualised transitional care plan should actually start by the age 11 to 12 and be very young person centred. So I think this is something we actually need to think about fairly early on. So the information transfer should be appropriate, and I think medical staff wise we're pretty good at this in terms of this patient had GIA, diagnosed age 2, was treated with joint injections, methotrexate, stopped the methotrexate because they were sick and the LFTs went off, and then they had, you know, we're good at doing a sort of chronology about the medical side, but I'm not quite sure how good we are at giving sort of full multidisciplinary handover, because as I said, GIA is a small part of a young person. It doesn't define them. So there's, you know, we need to think about that when transferring information over. We really try our best, I think, in paediatrics to try and minimise absence from school and college. Again, this can be tricky. For example, that's why in Glasgow we have our teen clinic on a Friday afternoon, because historically Friday afternoons were perhaps a time when schoolwork would, you know, maybe there was an earlier finish at school or a bit lighter, you know, it was felt less to break up the school week. So thinking about the young person's whole life as well. And really we should be copying our clinic letters to the young person ourselves. I know that varies across SPARN. So in Glasgow, it's not routine policy to copy the letter to the young person and family. I believe in Edinburgh, I believe Dr. Brennan does, but again, I'm not 100% sure on that. But you know, it seems, and Dr. Davidson used to, I'm sure, but it kind of, that is an important part of the young person and family feeling involved in what's happening about their care, and I think that's quite a nice thing to do, and I try to do it when I can. And then in terms of formalised transition checklists being advocated, I'm going to talk about the Ready Steady Go programme a bit later on to go through that. And obviously linking with primary care is essential going forward, particularly as the GP may take over certain prescriptions going forward. So how do we deliver this in Scotland? So you'll all be aware of SPARN, the managed clinical network for paediatric and adolescent rheumatology in Scotland. But as you can see, although we're a small country, we're a sort of fairly spread out country, and I think SPARN has been amazing for standardising care for young people with arthritis. So if you're on the Isle of Lewis or in Govan, you're going to get access to a paediatric rheumatologist, a physiotherapist, an occupational therapist, and we all talk to each other and we know who everyone is within the network, and that's a really lovely environment to think about. For example, if a child is going to university in Aberdeen and they've grown up in Glasgow, we can link into the Aberdeen rheumatology team via our paediatric rheumatology links in Aberdeen and get that, you know, we kind of know the geography and where everyone is, which helps deliver these services. And as I said, it was really just to standardise care, particularly for rare conditions, because I think although GIA has a similar prevalence to type 1 diabetes in children, I think for a lot of medical staff and doctors, GPs, the feeling that children and young people get arthritis is still quite a new one. And I'm not sure I had been that familiar with GIA before I actually finished medical school, to be honest with you. So I think there's still a long way to go. And the childhood arthritis prospective study that was going on for years, and some of you may have contributed data to that, you know, it showed that there's still a diagnostic delay in children with arthritis. Even, you know, 10 years on, there's still a diagnostic delay in young people with arthritis, because I don't think various health professionals are aware of it or believe that children have arthritis. So this is our attempt to try and get the right care at the right time for these children. So Sparn is old now. This is the 11th year, so it's been fab, and we all work very closely with each other. So you'll all know this, but just it is useful to know in terms of the transition. So knowing that there are the two sort of tertiary centres in Edinburgh and Glasgow, but the red dots on the map show all of the network and outreach clinics that we offer across Scotland, and each one has a link in with a local paediatrician with an interest in rheumatology and a multidisciplinary team. Supported by 4 paediatric rheumatologists. It used to be 5, but Dr. Davidson's retired. And this just illustrates how we try to give our young people the best care we can, no matter where they are in the country. This is, I won't go into this diagram, but this is really just to show you the established SPAR network centres that we have. So we've really got quite a lot. So we've got multi-level, multi-layer networking. And as I said, so transition can be locality-based, nationally based, UK, or even international. So it really depends on the child. So as I said, it could be local if they're staying in an area elsewhere in the UK, or Scotland if they're moving for jobs or university, or, you know, we've had patients who've moved countries, they're moving abroad, and we can, again, it's making sure that process of transferring information is sort of smooth. So we're heavily involved in education and training, and we have transition is something we fairly regularly talk about within our network. Dr. Walsh has a particular interest in transition. She's the consultant based in Glasgow, and she ran a fantastic transition day in, I think it was 2019, in Glasgow, a one-day event for rheumatologists and allied health professionals who have an interest in transition, and people came from all over the country, and it was a really good way to increase education about it, network, and get to know who's who and where they're based. So we do try to keep up to date. I'm a member of Banner, which is the Barbara Ansell National Network for Adolescent Rheumatology. So it's and that's made up of lots of rheumatologists and healthcare professionals across the UK who have a specific interest in transition. So I try and dial into their meetings, which are probably every 4 to 6 months. So we're always trying to keep up to date. We also do a lot of work with charities, as you probably know, and SNAC obviously being one of them. Versus Arthritis, which is an amalgamation of 2 organisations, are a really fantastic organisation, and in they have a lot of youth workers, one of whom is Claire Connor, who had GIA herself, and she does a lot of work with young people on transition. Pre-COVID in Glasgow, we had Versus Arthritis staff members in our Friday clinics, and that worked really well in our teen clinics, because you could Claire was probably down with the kids more than me, and the young people they could stop in and have a chat with her pre or post their clinic appointment. She would go through some transition paperwork with them. She could get information that maybe they didn't feel comfortable telling a doctor, but they could share in an informal chat setting. So Versus Arthritis has been amazing at making the transition process better, in my opinion. Claire, I emailed her today to say what's happening in COVID, because obviously I haven't seen you for so long, and she said, don't worry, we still are doing transition support we're doing it remotely over sort of video links. We're going through Ready Steady Go paperwork with young people, but we're doing it more on a if the clinician refers basis rather than a we're in clinic and you come and see us. So I think this is just something that that we all as rheumatologists need to bear in mind if we're seeing these young people in clinic, to think about this, but also it is about that giving that ownership to the families and young people to say, oh, wait a minute, you know, I'm 15. Should we not be doing some transition stuff? Oh yes, we should. Okay, great. Because it is just, it's trying to get that two-way communication going. And we do have the fab team from Versa Arthritis to support us. Yeah, please share your ideas, particularly young people. We always like to hear what would work for you guys. Would you like to see videos of the adult services, what their wards are like, what their day wards are like, what their doctors and nurses are like? Would you, you know, would that be useful, or would some sort of app about transition be helpful, or rather than, you know, doing paperwork, that kind of thing? Just please let us know if you have ideas, because I think this is the sort of thing where patients and young people's voices are the most important. So obstacles to an effective transition. So poor communication and information sharing between teams. I like to think that's getting better. Transition letters, particularly for, say someone's been diagnosed with arthritis at age 2 and they're transitioning to adult services when they're 18. That's a long journey to summarize in a letter, and we do it, but it's trying to pick out the relevant points. So I think that's important. Good written communication to make sure you've got a really good thorough transition letter, preferably with the young person family having a copy, and also verbal communication. So I know our local adult rheumatology team, and for example, I'll give an example. The other day I had a young woman who is nearly 18 with chronic pain who said the GP locum wouldn't give me another sick line because they say I'm able to work. And I said, okay. And she said, can you give me some advice about that and work? And I said, oh goodness, I said, to be honest, I don't know much about this, because most of our young people, you know, I haven't come across this very much, but I know exactly who I can ask. And I linked him with the adult vocational occupational therapist who deals with this day in, day out, and gave some really, really good advice and good support. So that kind of thing, communication on many levels is important from us. I also think it's well recognised that there's maybe poor adolescent specific training for adult rheumatologists, and that's hopefully improving. We've at what was the British Society of Paediatric and Adolescent Rheumatology, it's kind of amalgamated all within BSR, which means that at some of our meetings there have been an increasing number of adult rheumatologists attending. So I think there is a real thirst for that from the adult rheumatology side, that they want to feel more comfortable about these young people coming through, because it can be quite scary. Like if you put me in front of a 45-year-old or having a heart attack, I would be terrified. And I think it's the same the other way around from them. Shortage of resources is a major thing, particularly at the moment. And I was saying before we started the meeting, I was saying, you know, I just feel like we all want to do this better, actually. We really want to. But our clinics are so busy, and COVID has swept across the globe and turned everything upside down. And a lot of adult rheumatologists don't have job planning for transitions, so they can't give us, you know, a dedicated clinic. It'd be lovely to have a shared transition clinic. And, you know, there's lots of reasons why it doesn't always go the way we'd like it to go. And that's why we need to keep trying and keep a discussion happening about it, really. And there's no standard model for how it should be done, but there's a lot of guidance, there's a lot of suggestions, and there's a programme called Ready Steady Go that, as I said, I'll go into a bit more detail of shortly, which certainly in Glasgow and Edinburgh we feel is helpful. So in 2016, I think Dr. Walsh and Dr. Morrison looked at rheumatology transition services in Scotland, and they circulated a survey just to scope out what was happening in terms of transition across Scotland. So the first question, do you carry out a combined clinic with the paediatricians prior to transitioning patients to the adult service? 5 out of 7 said yes. Do you run a dedicated transition clinic within the adult service? And it was sort of roughly even split, but 4 of 7 said no. So I think that highlighted that the service provision is variable. And, you know, we really want there to be a Scottish standard for transition in rheumatology. And it's something we very much are aware of and want to improve. This was just, I think this was in Joe's slides, just to show the new hospital. That just a total divergence here. It was designed to be like a ship coming into dock. So the children's hospital is an oval circle, and that's like the docking bit. I'm not very good with ships. And the big adult hospital is the big ship towering into dock, because it's in Govan near the shipyards. So that's how it's designed. However, working in the children's hospital, it's just all circular, and if you just keep running, you will eventually find where you need to go, but it's a bit of a nightmare for the nurses to try and see what's going on with the patients. Anyway, so this is Hello to Adult Service, and this is Ready, Steady, Go, the programme I've been chatting about, which was developed by Arvind Nagra, who's a consultant nephrologist in Southampton Hospital. It's been around for about 5 years now, and I've heard her speak on a couple of occasions, and she is the most passionate, engaging, cares about young people person. Even if you Google Ready, Steady, Go video, there's a YouTube video of her talking about it, and I've watched it about 5 times because she's just so inspiring. And she published this in 2015 about a proposed programme for transition called Ready, Steady, Go to support that process, which should ideally start, say, around the age of 11, 12 is I think what they recommend in this. But if anyone's interested, this is a really good paper worth looking at, and it was in Archives of Disease in Childhood, and it's just, yeah, it's just really good. So I've taken some screenshots. So the common misconceptions around transition is, so some people think transition is when you just move to adult services. So 26th of May, Jimmy was transitioned. Actually, that's the transfer to adult services. The transition should have started years before. That is an ongoing process. Do you need to have a transition clinic in order to start transition? No, we don't have a transition clinic in Glasgow. This is something that can be done really by, you know, at any time in any setting, really. Can it begin without an identified adult team to which the care can be transferred? Well, yes, because a lot of the time the young people don't know where they're going to be going. They don't know if they're going to go to uni, or they haven't got the grades yet, or they just haven't decided where they want to do. So quite often we don't know where we're going to transfer a child to until fairly late on, but the whole process of transition can start early on. Now, this is interesting. Does a transition tool need to be subspecialty specific? And the feeling was, so for example, if you've got a child on dialysis, you're going to need to talk about where the adult hemodialysis ward is and who they phone if they think, you know, there are going to be disease specific things. But in general, a lot of the issues faced by the young people during this process are generic, regardless of what their underlying condition is, which is why I think Ready, Steady, Go is so good, because it's been used by cardiology, diabetes, nephrology, rheumatology. It's a very good thing. Can a young person with learning disabilities undergo transition? Absolutely. And it's quite sometimes, for example, the paperwork will be gone through with a carer along with the young person rather than the young person themselves. And what age should this happen? So the studies show that starting around 11 or 12 years of age leads to better knowledge and skills. And for example, you know, I quite often will ask the young people, what medicine are you on? You tell me, what's that for? When do you take it? You know, I kind of quiz them a bit, because, and then if they don't know, I say, right, your homework for next time is you're going to tell me what your meds, you know, tell me what the name of that medicine that you have once every 2 weeks is, or you know. And it's not that I'm trying to be annoying, because I'm sure I do annoy them, but it's just to try and get them to take a bit of ownership and interest in their own condition, because it's their body and it's their, if they don't really know what this is, and my mum jags me every 2 weeks, I don't really know, I just do it, and I want to go and play Minecraft, fine. But actually, if you know that that's my Humira every 2 weeks and it's starting to really annoy me and I don't like it, if you know what it is, you're maybe feel more able to have a voice and say, wait a minute, you know. It's just about increasing that knowledge. And then what else am I? Yes, is it right to introduce the additional goal of effective transition who are already going through significant changes associated with adolescence? Well, yes, I mean, you can't get away from being an adolescent. It's not exactly an easy time. It's going to be hard no matter what time you start doing this. So I think the earlier the better, personally. So RACE-CYGO is a holistic program. It's done gradually, and there's a series of questionnaires which are prompts. They're not a checklist. You don't sit there with a pen saying, right, tick, tick, tick. It's more and you don't have to go through each prompt on each checklist. Or sorry, each questionnaire. You can be quite selective in which ones you think are relevant, or if, oh, I don't think we'll go into this question at this time, that's maybe a bit too soon for them. But general things, you know, it goes through medication, who to ask for help. And I really like the patient advocacy. So ask 3 questions. So to teach the young person, no matter what age you are, if you're 16 or 60, if you have some issue with your health and you don't really know what to ask, but you feel like you want to know more about it, just ask the 3 questions. So what are my options? What are the pros and cons of each? And how do I get support to help me make a decision that's right for me? And you can't go wrong with those 3 questions. And those 3 questions will naturally empower the person to, if they don't really know how to ask what they want to ask, I think these questions will encompass a lot of the information that they want to get out of it. And if there's any big treatment decisions having to be made, these ask 3 questions will hopefully empower the young person to get involved and not let mum and dad just do all the talking and or the doctor do all the talking, but them to have their voice heard. And I really like the concept of there shouldn't be a decision about me without me. So, you know, because I'm guilty of it. I'm guilty of, okay, so we are going to start this medicine, you know. I'm guilty of it. While the young person's sitting there thinking, well, wait a minute. And I think a sort of, are you okay with that, Jimmy, is not good enough. Because of course they're going to say, or go quiet, or, you know, it's more well, let's have a chat, let's look at your options, let's look at the pros and cons of each, and how can we support you to make that decision. So is it that you need to have a pause, go away with some information leaflets and chat to mum and dad? Is it that you need to chat to our rheumatology nurses, or see the medication pens, or you know, what do you need to come to a decision? Because everyone's different. So I just think these 3 questions are quite helpful. And I actually think we should put posters. We're not allowed to put posters up because for infection control, particularly at the minute. But, you know, it would be nice to have this in a clinic room to encourage the young people to do this. So Care Quality Commission, as I said, they've got a document called From the Pond into the Sea, which is detailing their recommendations for transition from children's to adult services. They say there should be a key accountable individual responsible for supporting the move. So that would tend to be the sort of named consultant, but actually practically on the ground, you know, I know that Imogen Kelly, one of the nurses in Edinburgh, she certainly pre-COVID, she would really endeavour to go to the first adult appointment with the families if she could, to support them. And our nurses in Glasgow really try to do that when they can. But having someone who's going to support that move, or whether it's Claire versus arthritis, a documented transition plan. So for me, that tends to be in the letter, mostly. Communication or health passport. to ensure the professionals have access to the essential information. So again, that will depend where you are in the country. In Glasgow, if they're going locally, we all share the same clinical portal system, so our adult colleagues can see everything that's happened before, so that's less relevant to us, but it may be something to think about in your own area. And then let's have a look, health services in an appropriate environment. So I find this hard because to me, it is straight from the pond into the sea. You go from this, you know, comfortable, very friendly children's hospital to the adult hospital, which is fab, but it's different and it has its own pressures. And so I think that's hard. If I could have my way, I would have adolescent hospitals in Scotland, England, Wales and Northern Ireland, and just a complete hospital for adolescents where it's just completely designed for them in mind. I know that the Teenage Cancer Trust are fab, and they have special teenage rooms and areas within the oncology wards so that teenagers undergoing chemo can go and just have their own space. I kind of feel like we need more teenage appropriate environments in clinics actually. Thinking about how we do that, I feel like I heard something at a transition day that some people were doing their clinics in like youth centres or even like a sexual health clinic, doing a clinic in there, like, you know, just thinking about environment that's more adolescent friendly is something that I think we could improve on. Training and advice to prepare them and parents for the transition, because that can be hard when your baby, who's always going to be your baby, has been unwell since they were 2 and you've worried about them for 16 years and you've been to every appointment and you've been to every joint injection and you've held their hand through every blood test, to suddenly have a doctor like me who you maybe don't know very well say, well, why don't you come in first, Jimmy, and then we'll get mum or dad in after. That's quite a, you know, the shock I've seen on parents' faces. You know, and I don't blame parents. You know, I'm a parent. I think it's hard to sort of that sort of transition for a parent as well as for the child. So I think in an ideal world, what I like to say to the young people is, so you've done your appointment really well. Next time, why don't we try that you come in yourself first? Next time I'll ask you to come in on your own and then we'll get mum or dad in after. Are you okay with that? So it's not kind of sprung on people and the family and young person have time to process that. Children's services should be provided till adult services take over, and that's still the case. Certainly in COVID times, I mean, the adult wait list in Glasgow is about a year at the moment, so we're just keeping our young people until they've been seen by adults really. So we're hanging on to them, and similarly for those on infusions in the day ward, we hang on to them till they've had their first infusion, and the you know, we'll keep doing the home care prescriptions until that's all kind of swapped over. So yeah, it's a structured framework covering all of these issues. And this is where I'll maybe give my slightly comical anecdote, not antidote. So Dr. Arvind Nagra, who I was telling you about, who designed the Ready Steady Go, I remember watching her talk, and she's a nephrologist and she works with 2 male colleagues, and there was a young man in her clinic. And she said, we'll call him Jimmy as well. So Jimmy, have you started masturbating yet? And he went a bit shy. She said, oh, is it dry? Because he was on a medicine called enalapril that causes retrograde ejaculation. So the ejaculate goes into the bladder instead, you know. And he said, oh yeah, it is dry. It is dry. And all my friends have been talking about dumping their load for 2 years and I didn't know what they meant because mine was dry. And then she said, okay, so it's glad we, you know, we can have a chat about this. And he said, oh, it's just because I know you, or she said something like, but you see my male colleagues quite often, why have you not, you know, brought this up before? And he said, oh, it's just because I know you better, Dr. Nagra. And she said, it's not because you know me better, it's because I asked the question. And I think there's actually a lot to be said for that. Maybe opening these discussions and conversations that can be things that maybe may seem a bit uncomfortable. You know, he said, oh, it's just because I know you better. And she thought afterwards, no, it's because I asked the question. That's why it came out. So that story's always stuck with me because you know, I'm not particularly backwards in coming forwards. I'll just go straight in there with the questions with the young people, because I think if you normalise these questions and these topics, then they're more likely to speak. I think I'm about to get invaded by a 5-year-old. Hello, Eve darling, mummy's just doing some work at the minute. Hello. Will you sit very quietly if you want to watch? You promise? Okay, good girl. Sorry. Right, so this is the Ready Steady Go. This is the sort of timeline. So as you can see, starts at 11, goes all the way through to the first adult appointment, and it's sort of red, amber, green like traffic lights. And I'll show you some of the so when it comes to the transition to adult services, ideally the first visit would be a long one. So in Glasgow, our local teams do an hour consultation for their first one with the young person and the family to really get an idea of the full history. And ideally, as I said, our rheumatology clinical nurse specialist would endeavour to go with them. Are you the one with the green line around? Am I the one with the green line around? No, darling. My camera's off. No, they're the mummies and daddies listening. Okay, so let's just listen. Good girl. Sorry. So then an offer for them to go and see the day unit afterwards if it's applicable. So if they're going to have infusions. So again, this is pre-COVID. They would have a visit and a look around. And Mommy, this means most of the Grinch. I missed the Grinch. Evie, could you go? Oh, okay. Well, why don't you go watch the rest of the Grinch? And I'm sorry, everyone. Evie, you need to go and see Nina. No. Right. Shh, you have to be quiet. So this hopefully offers some flexibility for the family young person. Right. Goodbye. No, sorry, guys. Eve, really, honestly, do you want a smiley face on your chart? No. You have to go. Russ, yeah. Can you come and wait, Eve? Eve, go. Sorry. So practical issues like making sure the biologic prescription is handed over, getting the next infusion at the day unit, all these sorts of things, and making sure they have contact details for the adult services. Daryl McGee's the adult rheumatology nurse in Glasgow, and she's fab. She quite often gives the young person a ring, just have a chat, introduce herself, see if there's any issues that she can help with before that. And yeah, this is just to highlight the prescription issues. So these are things that sort of work well. I won't go through it. It's mostly things I've said already, to be honest. But this is what we find works well in Glasgow. And as I said, it will be different across the country. So can we measure outcome in transition services? So things that we think are indicators of a successful transition are the patient isn't lost to follow-up, so they continue to attend visits in adult care. They maintain or improve their disease control. So for example, we don't really like sending a patient to adults if they're flaring, because we don't feel that's not a good time to move someone and have change, especially if we've known them in our service for many years. So we really avoid sending a child who's flaring. We would not be keen on that. We want the young person to continue to look after themselves and for the patient and family to be satisfied with how everything's gone. And again, I think the feeling was a number of, in this paper anyway, an indicator of successful transition would be maybe not having a huge number of emergency room visits for routine care. So the feeling that your care is being adequately overseen by your team and you're not feeling the need to go to ED, or maybe that's suggesting poor disease control, all that sort of thing. However, it didn't mention educational work objectives, and I think they're important outcomes as well. So what do we know about employment in adults with JIA? So successful transition from school to work is, or college, university, is important for young people, especially those who have been living with a chronic illness or condition. There was a paper that looked at long-term follow-up of just under 250 adults with JIA in terms of education and employment. And the rate of unemployment in this group was more than twice that in the national population. I think this was Canadian, I'll double check where this is from. And about a quarter had encountered some sort of discrimination in the workplace. Whether that be because GIA isn't a particularly visible condition. You can have a young person who perhaps is having a flare, but there's not much to see from, you know, a work colleague in an office, and therefore maybe understanding of that could potentially lead to some sort of discrimination in the workplace, you know, that sort of lack of understanding. Or like the young woman I was telling you about earlier with the locum GP saying, oh, well, you can work, I'm not signing your sick line again, you know, these sort of things that can maybe make it a tricky one. Therefore, empowering our young people to be able to say and to understand their condition and speak and advocate for themselves, to explain their needs, would be important. And having spent some time with Elaine Morrison in adult rheumatology clinics, I think she felt that vocational support is extremely important, because it may be that there are some jobs that are a bit more tricky, hopefully not, hopefully everything's very well controlled, but she said, you know, really having that vocational support and knowledge and understanding of the processes is essential. And that's why I think we are keen to build links with the adult OTs who are more knowledgeable about this than us, and having those links is very important. This was looking at adults who'd had childhood onset rheumatic disease in Catalonia, so in Spain, and looking at their employment rate and social status. And a low GIA and rheumatological treatment is advancing at a very fast rate and is much improved compared to how it was 10, 20 years ago. It was found that these young people took longer to complete their studies and enter the workplace, and generally had a lower employment rate. So I think it's important to be mindful of these things so that we can adequately support young people in what they want to do. So yes, that's just factors influencing employment, of which there are many, as you can see. But I think vocational OT and good support are absolutely essential. So this is just to highlight some documents. The GMC has guidance for us about looking after children from 0 to 18, sort of consent, confidentiality, all that sort of thing. And these sort of posters just to highlight that we want children, young people to feel able to, we want them to feel respected, listened to, and that they can speak. So essentially, sorry, I feel that's a lot of waffling and a lot of talking, but really, I just wanted to provide an overview of what transition is, what the process is, that in an ideal world, it would start early and be an ongoing thing that you tailor to the young person. But also, and if we have a good transition for a young person, it should result in better medical outcomes going into adult services. And at the moment, although things are a bit up in the air with COVID, and I think everyone in paediatric rheumatology in Scotland at the moment would say, I think they'd agree with me that I don't think transition is being done how any of us would like it to be at the moment, and that can be very frustrating as a health professional. But we're very aware and trying, and would be extremely open and grateful for any thoughts, feelings, suggestions. So thank you for listening to all the waffle. Apologies for my child. And I'd be happy to take any questions if anyone has any.